This is the Juvenile Idiopathic Arthritis, or JIA, case study by Katie Levin, MSN-RN. Due date is November 30th, 2025. The class is FNP3. The professors are Hoyson and Wright, and this is for Youngstown State University. So what is it? It is a chronic autoimmune disease. So the immune system attacks the body's own joints. It causes joint inflammation, stiffness, and pain. This occurs in children under the age of 16 and is the most common type of childhood arthritis. So for the introduction, Emma is a 9-year-old girl. She is brought into the pediatric rheumatology clinic by her mother, and Emma is complaining of persistent joint pain and swelling. Over the past 3 months, her mother says that Emma has complained of morning stiffness, especially in her knees and ankles, and it roughly lasts about 45 minutes each morning. She also has been limping sometimes, particularly after waking up. She seems more fatigued than usual, and she is resisting playing on her soccer team. Symptomatology: joint pain, intermittent but progressively worse, especially in knees and ankles. Morning stiffness: it's roughly about 45 minutes, so it's prolonged, improving somewhat during the day. Swelling: intermittent swelling noted in both the knees. Gait changes: occasional limp, especially in the morning or after rest. Fatigue: increased tiredness, reluctance in physical activity she previously enjoyed, such as soccer. No systemic symptoms, so there's no fever, rash, weight loss, or significant night sweats. So these are the questions I would ask the patient/caregiver to get a more understanding of what's going on. So some of the questions would include onset and duration. So when did you first notice the stiffness, pain, or swelling? And then has it gotten gradually worse, or has it come in flares? The pattern: which joints hurt? Is it both sides, or is it only one side? Does anything make it worse or better, such as activity, rest, heat, or cold? And then we have morning symptoms. So for asking this, we would ask, how long does the stiffness last after walking? Do you feel better after moving around? Then we would go to functional impact. How is it affecting your daily life? Have you been avoiding activities that you used to enjoy? Then we would go to systemic symptoms. Have you noticed any fevers, rashes, weight changes, or night sweats? And are you having any eye symptoms, such as redness, pain, or vision changes? We would go to previous treatment/responses after that. And then, have you tried any medications, such as Tylenol, NSAIDs, Voltaren gel? And then, did they help or did they not help? If they did help, how long did they help for? And then, have you had any joint injections in the past? After that, we would go to family history. Does anyone in your family have a history of arthritis, either in adulthood or juvenile? Does anyone have an autoimmune disorder that we need to be aware of? Any history of rheumatologic disease or psoriasis? We would go to growth and development next. Are you meeting your developmental milestones? Any growth concerns? This one would mainly go to the caregiver, since the patient is pediatric and most likely wouldn't know the answer to this. Medication adherence and side effects. Are you currently taking any medications? Are you having any side effects from any medications? Are you up to date on all your immunizations? And then psychosocial. How are you coping emotionally? Is this affecting peer relationships, your relationship with others at school, your family relationship, anything like that? So next we're going to go to medical history. For birth and early childhood, she was full term. There was no prenatal complications. She is up to date on all her vaccinations. For previous illnesses, there's just occasional upper respiratory infections, but no hospitalizations. For medication history, it's just over-the-counter ibuprofen or Tylenol as needed for her pain. She has not had any surgical history done, and she has no known drug allergies. For family history, her mother does have an autoimmune disorder, hypothyroidism. Her maternal aunt does have rheumatoid arthritis. She did that as an adult. There's no family history of psoriasis, lupus, or other rheumatologic disorders in her siblings or other family members. Social and developmental history. She lives with her parents and a younger brother who is 4 years old and is named Brian. She is active in school, church, and soccer. No tobacco exposure, no alcohol exposure. Her diet is balanced. Mom Patricia says that she is picky about her vegetables, but she does eat them. At today's visit, Emma's vital signs include a temperature of 98.4 degrees Fahrenheit, a heart rate of 90 beats per minute, a respiratory rate of 18 breaths per minute, blood pressure of 105/65, and that was taken in her right arm. Height is in the 50th percentile and is 135 centimeters. Her weight is in the 60th percentile and is 32 kilograms. Like previously mentioned, she is taking ibuprofen, 200 milligrams every 6 to 8 hours as needed for pain, and she does alternate that with Tylenol, 12.5 milliliters every 4 hours as needed for pain. The ibuprofen is usually 3 to 4 times a week, and Mom states that the Tylenol is occasionally taken. However, the ibuprofen is taken more than the Tylenol. Now we're going to move on to the physical exam. In general, she is well appearing, alert, cooperative, and in no acute distress. Her gait is slight antalgic gait favoring the right knee in the morning. For her knees, both knees show mild swelling, more pronounced on the right side. They are warm to touch, no erythema. On palpitation, there is some tenderness, particularly along the joint line. Range of motion, there is slight decreased flexion on the right. The extension is full though, and this is for the knees. For ankles, there's mild tenderness on medial malleus bilaterally, but there's no obvious swelling. Wrist and hands, no swelling, full range of motion, they are warm. She has no history of Raynaud's disease. Elbows are within normal limits. TMJ, her jaw opens fully, there's no obvious jaw pain or limitation. She has no pain when eating. She does have all her teeth. Spine, there's no tenderness. She has full range of motion for her spine. Skin, there's no rashes, no psoriatic plaques, no nodules. Her eyes are no redness, conjunctiva clear. She does see her optometrist regularly. And then all the other systems such as cardiac, pulmonary, abdominal, and neurological are all within normal limits as well. Alright, next we're going to go to the differential diagnoses. And the top one that we have is juvenile idiopathic arthritis. And this is most likely because of the chronic joint pain, morning stiffness, swelling, involvement of large joints such as the knees and ankles, and insidious onset. The absence of systemic symptoms such as fever and rash suggest a non-systemic subtype. Next, we're going to go to growing pains. This is common in children. It can present as lung pain, but is not typically associated with swelling, morning stiffness, or prolonged joint swelling, and it does not produce objective joint findings. So then we're going to go to reactive arthritis. This could follow a prior infection, a GI or GU infection, but there is no documented infection, systemic illness, or laboratory evidence of reactive arthritis. Also, reactive arthritis tends to be more acute rather than chronic. Less likely, however, should still be considered is Lyme arthritis. This depends on the geographic risk, trauma, or bleeding disorder, though no trauma history or bleeding signs or geographic evidence that this could be an issue for the patient. Alright, so we're going to go to lab test. We're going to do a CBC with DIF to check for anemia, leukocytosis. We're going to do an ESR and CRP, which are markers for inflammation. We're going to do a rheumatoid factor to classify a subtype. We're going to do an ANA associated with ocular articular risk. We're going to do an HLA-B27 This is if arthritis is suspected. We're going to do a ferritin, liver function test, renal test to get a baseline before treatment. And we're going to get immunization titers on status, which we do know that she is up to date on all her immunizations per her mom at this appointment. Next, we're going to go to imaging. So we're going to do x-rays with plain radiographs of the affected joints. In this case, that is the knees and ankles, to assess for joint space narrowing, bone erosions, growth plate involvement. We're going to do the ultrasound of joints, again, knees and ankles, to detect effusion, synovial hypertrophy, and guide joint injections if needed. We can also do an MRI. In children with suspected subclinical joint involvement, MRI can detect early synovitis before X-ray changes are shown. Alright, so now we're going to go over Emma's results. So the CBC showed mild anemia, hemoglobin is 11.5, normal WBC, her platelets were slightly elevated, her ESR was elevated at 35, CRP was elevated at 2.8, her RF was negative, her ANA was positive, it was 1 to 160, homogeneous, her HLA-B27 was negative, and her liver and renal function were all within normal limits. Her knee x-ray did show mild soft tissue swelling, no erosion, preserved joint space, no bone destruction, and her ultrasound showed moderate synovial effusion, synovial hypertrophy, and Doppler signal consistent with active synovitis, and that was of her right knee. The primary diagnosis for Emma would be JIA, juvenile idiopathic arthritis, oblique articular JIA, and that is because this is chronic joint involvement limited to a few joints, which are the knees and ankles. There's morning stiffness, and there's elevated inflammatory markers which support this diagnosis. There's a negative RF and anti-CCP and positive ANA, which are consistent with this diagnosis. So that's what's leading me to this diagnosis also, that are showing signs of this diagnosis include the imaging, the synovitis without erosions, which shows the early and mild disease form. And then the other causes, like the reactive arthritis and infection, are less likely given the absence of infection history and that this is a chronic problem. So this slide just goes over the criteria for JIA that we talked about as the primary diagnosis. It goes over the treatment plan, the effects, normal knee joint, the inflamed knee joint, possible complications, pediatric rheumatology team, differential diagnoses, and the subtypes. So if you have a moment, just read through this, and it kind of guides you through how I came to the diagnosis of JIA for Emma as well. So then we're going to start with the treatment plan. And so this is going to be an intra-articular glucocorticoid injection. And the normal amount for this is 1 milligram per kilogram up to 40 milligrams. So we're going to do this in the right knee since this is the most affected joint for Emma. This is strongly recommended by the ACR guidelines. And the injection can provide local relief and reduce systemic exposure. After that, we're going to do NSAIDs. We're going to continue ibuprofen, but adjust to a scheduled regimen rather than just PRN per recommendations while other therapy takes effect. And we're going to taper the NSAIDs once the DMARD therapy becomes effective. So then next we're going to DMARDs, which are disease-modifying anti-rheumatic drugs. And we're going to do methotrexate, and it's going to be 10 to 15 milligrams per m squared per week. So we're going to start low dose weekly doses, and then we're going to alternate DMARDs in this if the intra-articular steroids and NSAIDs are insufficient. And then we're going to do a biologic therapy, such as a TNF inhibitor, if the methotrexate does not work after 3 to 6 months. And we're going to do Intracept, 0.8 milligrams per kilogram, sub-Q weekly. If the disease activity remains, we're going to do this as recommended by the ACR for moderate to high disease activity. So we want to test the NSAIDs, DMARDs, and the methotrexate first before we try the TNF inhibitors. So this is the treatment plan continued. We want to make sure that we get baseline labs before starting methotrexate, which includes the LFTs, renal, and CBC. That way we can see if there's any changes while she is getting this treatment. We are going to do family education and patient education, letting them know what this disease is, the treatment options, goals, medications, side effects, how this could affect her or her family. We want to make sure that the family and patient fully understands what is going on. We also want to do a folic acid supplement when we do methotrexate. We want to do regular monitoring per the ACR non-pharmacologic and medication monitoring guidelines. So for this, we would do blood labs that I just mentioned every 3 months. And then immunizations, we want to make sure that she is staying up to date on everything. She is getting age-appropriate vaccines when they are due, and she coordinates live vaccines carefully because they do have an effect on the body when this disease is present. We also want to make sure that the patient is included in decision making. We don't want the caregiver to have all the autonomy since this is her body and she should make decisions as well. We want to make sure there's psychosocial support such as emotional and coping strategies, as this is a difficult disease for juveniles to really comprehend and manage themselves. And for exercise, I would recommend swimming, yoga, and bicycling. Alright, follow-up plan. Short term, for the first 3 to 6 months, we're going to reassess in 4 weeks to check response to the intra-articular injection and NSAIDs. We're going to monitor the labs every 8 to 12 weeks after starting methotrexate. We're going to start physical therapy weekly or bi-weekly during initiation and then adjust as needed. And then we can adjust NSAID dose as needed and consider taping once the DMARD's effect is evident. And then we're going to go to intermediate, which is 6 to 12 months mark. We're going to reevaluate the disease activity on clinical exam. We're going to reevaluate the lab work, and we could possibly do an ultrasound to assess the synovitis. If there's an inadequate response after 3 to 6 months on methotrexate and the injection, we can consider starting a biologic therapy. We would reinforce therapy adherence, monitor for side effects, and continue PT and OT. So long term, which is a year and greater, the goal is to achieve an active disease or clinical remission. Once stable in active disease, discuss tapering strategy, long-term safety monitoring of treatments and lab work, and we're going to discuss transition planning once the juvenile reaches the point where she goes into adolescence or adulthood and needs to switch practices. So these are some resources that I found online. The University Hospital and Cleveland Clinic have locations all over which have support groups that you can go to. They're not really scheduled, they're just random days and times, they're not every month, so you would really have to go online and see when these events are. However, they do have online information if needed. The CDC also has pamphlets and support groups and online information for anyone with this disease. I also have 2 websites that talk about all of the disease, and it also talks about arthritis in adults. It is just really good information for families and the patient to get a general grasp on what's going on and assist them in growing their knowledge in either the psychosocial support, treatment options, or what this disease is. There are also pamphlets and more information at local doctor's offices or local hospitals that can help you. And then if you search online too, there are also social groups or support groups that are specific to different areas that meet at different times that you can go to that will assist you as well. So thank you for taking the time to listen/watch this presentation. I hope it gives you a good clinical insight on juvenile idiopathic arthritis, or JIA. The next slides, I do have the references. The first one is over the pictures. The second one is over the information. But if you have any questions or concerns, please let me know. I'm not going to read the references, but they are in APA format. That way, if you want to look at them and find out more information, you do have that record there. Again, if you have any questions or concerns, please let me know, and thank you for listening and spending time on this presentation.